I want to start just by thanking all of our participants today, and for sure our panelists for joining us in this series that Siren is calling our Hot Topics discussion series. Today's topic, as you know, is lessons from the Camden Coalition's Care Management RCT. I'm really, really delighted to be able to introduce, an incredible lineup. I feel like we have this all-star lineup today, and I just, even in our prep calls for this webinar, I just didn't ever want the conversation to stop. So I'm hoping that even after this hour, that this conversation keeps going, both between these groups, and then between all of you and the panelists, and then between all of you without the panelists. It's just such an honor to have Amy Finkelstein and Erin Truchel kicking us off with a summary about their groundbreaking randomized trial that was really a collaboration between the JPAL team at MIT and the Camden Coalition. Amy is a professor of economics at MIT and the co-director of research associate of the public health of the public economics program at the National Bureau of Economic Research, and the co-scientific director of JPAL North America. Erin Truchel is the senior director of analytics at the Camden Coalition. Following that scientific presentation, I have the enormous honor of moderating a panel conversation with our three invited discussants. Kathleen Noonan is the president and chief executive officer at the Camden Coalition. Kedar Mate is the president and chief executive officer at the Institute for Healthcare Improvement. I was lucky enough to work with Kedar on the National Academy of Sciences, Engineering, and Medicine Committee on Integrating Social Care into Healthcare to improve the nation's health from 2018 to 2019. And it's great to have him join us today. Damon Francis is the medical director of the Homeless Health Center at Alameda Health System and former chief medical officer of Health Leads. Damon has been a much valued Siren thought partner and has served on the Siren National Advisory Committee since its inception. So you can see why I'm so excited about today's panel. I know these people, they're brilliant, and they're just thinking about this work in so many interesting ways. So big thank you to the whole group for spending time with us today. Okay. Have to do a little bit of logistics for you before we dive into today's content. So the webinar is being recorded. We always get that question in the Q&A. It is being recorded. We will send a link out to the recording to all registered participants when it's available. We also welcome your questions, so please use the Q&A function, not the chat function, to ask your questions and add comments. If you put it in the chat, it just takes longer for us to get to it. Okay, and then a couple of things about upcoming events. So this is the first of a two-parter. So the second part of this Camden Coalition RCT discussion is actually going to be hosted by the Camden Coalition next month, and they are hosting a conversation with their consumers to talk about their perspectives on the findings that have emerged from 2020 to 2024. And I think it promises to be a really interesting conversation. So please use the QR code or just find the information about the conversation on our website and register. And then I have two really exciting announcements too. Siren podcasts are on their way back. Make sure to subscribe to the Siren podcast series on your favorite podcast app. Be the first to listen to our new episodes. And then, we have officially decided to do our third National Research Conference with much pressure from our advisors. So in February 2025, we are going to convene in person again, like in our 2019 meeting, and actually see each other. Crazy idea. We should have more details about location and specific dates in February coming soon, but please stay tuned for that. Okay, I think my job here is almost done. So I am going to stop sharing. And I'm going to turn the mic over to Erin and Amy to share their slides and give us a kind of 15-minute synopsis of all the amazing things that they have learned over the course of the last many years.
Thank you so much, Laura. Let me just share my screen. Good morning, everybody. I'm Aaron Truschel, and I lead our data team at the Camden Coalition. We're going to be presenting two studies that have come out since the original RCT on our core model. I'm assuming if you're here today, you have some baseline familiarity with the model, but briefly, we want to kind of talk about what it is that we do, what led us to the partnership with JPAL and doing an RCT. Um, One of our earliest efforts at the Camden Coalition was to bring together competing hospital systems to build an integrated data system that linked individual level data from across the community. And from that, we saw high concentrations of costs. And our core to our mission has been understanding the drivers of the overutilization, and really, that's highlighted the intersection of clinical and social complexity. So back in 2009, 2010, we started building our care model that we now call the Camden Core Model. It's always been a process of iterating and evolving as we learn. So, we've been doing this for about 15 years now. Some things have stayed constant through that period of time. We've always been running interdisciplinary teams. It's always been very community-based, where we're not just working within the healthcare system. We're going out and meeting patients where they're at their homes and the places that they, go for care. There's always been a commitment to broadening that traditional medical-centric goals to being more holistic and patient-centered focus. And as we solidified the program, we've settled on the criteria that you've seen here. So the common theme is complexity, although there's certainly a significant amount of variation. Patients as young as 18, 20 years old as up to 80 years old. Multiple hospital admissions, multiple chronic conditions, and markers of social complexity. And so, I think this has been a pathway very well, as you'll see later on, to flagging highly complex patients that are at risk. What led us to an RCT and partnering with Amy and JPAL was, as we grew this model, there was just a proliferation of interest in this work. We had the Affordable Care Act, so much shifting towards value-based payment models. It was obviously accelerated by a high-profile piece in the Atul Gawande, or by Atul Gawande in the New Yorker. We were working with communities across the country to teach and grow the model. And although we had some preliminary evaluation work, some of it internal, some of it that we've done in partnership with managed care organization partners, that had very encouraging success. When we looked at evidence-based programs like Nurse Family Partnership with multi-decade spans of rigorous evaluation, we really wanted to hold ourselves in the field to this higher standard of research and evaluation. So there was certainly some limited evidence at the time that care management strategies were successful, but not for the most complex patient segments that we were working with. So 2013, 2014, we started the conversations with JPAL. It was still, we're a couple years into building the model, but we thought we were at this sweet spot of, well, we had a multi-year stable funding period through a CMMI grant. We had a strong research partner in JPAL North America. And so, there's never the perfect time to launch into an RCT, but certainly we saw it as a really good time to kind of step up and try and, demonstrate what works and learn from that. So with that, we started the partnership with Amy, and I'm going to hand it over to her.
Thanks very much. I'm going to just talk briefly about the original study and one of our follow-up studies, and then turn it back to Aaron to talk about another follow-up study that he's conducted. Let me just say at the outset that it has been a joy, an honor, and a privilege to work with the Camden Coalition. And if you take one thing away from this entire webinar, or at least our part of it, or my part of it, it's that, what Aaron said about the importance and value of doing this kind of rigorous research, as he said, holding ourselves to the kind of standard we apply when, trying to figure out what medical interventions are most effective, learning from what we find and innovating and continuing based on it is just incredibly important. As Aaron mentioned, I run this center at MIT, JPAL North America, which is a network of academics around the country. Our goal is to support and encourage and help with randomized evaluations on critical policy issues. My personal passion is healthcare, and we hope that we're doing many more, and we hope that some of you listening in might be inspired to reach out and learn more about whether we can partner with you as well. So just to very briefly describe what we've done and found so far, working with the Camden Coalition, we prospectively enrolled 800 patients at the time of admission into this randomized trial. And again, in collaboration with the coalition, we pre-specified our primary outcome to be any readmission within 180 days of discharge. And Aaron, if you can go to the next slide, one more. Oh, okay. What we found is that this is a graph showing relative to the index admission, what was happening to the number of admissions in the treatment group in red and in the control group in blue. And what you see is, not surprisingly for a randomized evaluation, they're very similar before the intervention. And in addition, you can see a strong uptick in hospital admissions right before the intervention. And then what you see in the orange in the treatment group is a big decline in the 2 quarters after the intervention, that 180 days, but unfortunately a similar decline in the control group. So if you can go to the next slide, in other words, we found no impact on readmissions. And we also learned an important lesson about how if we hadn't done this rigorous RCT, we might have gotten a very different and incorrect conclusion because of this problem in healthcare in general. And with interventions, you intervene on sick populations, and there's a big tendency to revert to the mean. So things often get better after the intervention, but as you saw, they got better in the control group as well. So this got a lot of attention. And if you go to the next slide, Aaron, it also generated a lot of debate about, what do these results mean and what should we take away from them? And again, J-PAL North America is committed to not just being the hired hand that comes in and does the randomized evaluation, but trying to work with the partner to listen to what they're learning from the results, whatever they are, and to do further study and then innovation based on that. So if you go to the next slide, this, as I said, we've had a bunch of follow-up research. I'm going to talk briefly about the bottom one, the health affairs piece that just came out, that was a joint collaboration between the team at MIT, at J-PAL, a team at the Camden Coalition, and a team at Rutgers Center for State Health Policy. So if you go to the next slide, you can just have it all come up. The key question that, we were interested in is something we heard being debated a lot, which was, why did the intervention fail to reduce hospital admissions at 180 days? Was it because the model was not implemented with fidelity, and so the intermediate goals of getting patients connected to their primary care physician on their prescription medications, et cetera, weren't met? Or was it successfully implemented, but the theory of change, which is that if you connect these very complex vulnerable patients to existing resources, that would be sufficient to break this cycle of hospital admissions? Was it a failure of the theory of change? As I said, the sort of intermediate goal was to connect patients to care in the community, and we weren't able to really look at that in the first paper because we had terrific data from the Camden Coalition on, how much interaction they were having with the treatment group, but the control group was sort of a black box because we only could see hospital readmissions. So we partnered with the Rutgers Center to get to link the study participants to data from their Medicaid records in New Jersey in order to look at these, sort of theory of change inputs on what is the impact of the program on increasing office-based care and other types of measures. So if you go to the next slide, what we found is that the program caused an immediate and persistent increase in outpatient office care. Both primary care and specialty care increased. So there was actually a considerable success in meeting the implementation goals. In fact, the increase in visits that we estimated was similar to what other successful care coordination programs have found. We had a sort of 10 to 15 percentage point increase in outpatient care. And in the absence of the program, we're finding, only about a quarter of patients are receiving timely office care after 2 weeks, so that's a big increase. We also found some evidence of an increase in the proportion of patients receiving durable medical equipment, no impact on home healthcare use, and no effect on prescription drugs. So if you go to the next slide, this just shows you some of these results. It shows the, I think, quite impressive finding for the office-based visits that you go from about 25% of the control group having this timely post-discharge office-based visit to a 15 percentage point increase in that proportion due to the Camden Coalition model. This effect persists out to 365 days. And in fact, if you go to our last slide, or our second to last slide, what you see, we're now showing both primary care and specialty care and breaking it out by different time periods. You see that, the coalition's model immediately increases use of outpatient care, and that effect actually increases over time. It's driven primarily by an increase in primary care, not specialty care. And so if you go to the last slide, I think of ours, what we concluded based on this is actually, it looks like relative to other successful models, the Camden Coalition was implemented with great fidelity and success. They were increasing use of outpatient care, a key marker, but that it seems that this care coordination alone, even when well implemented, is insufficient to reduce hospitalizations for this extremely complex population of high need patients. As Aaron alluded to, there had been earlier RCTs finding success for less complex populations. And I think that's where some of the work that Aaron's now going to talk about may come in into unpacking what's going on.
Yeah, thank you, Amy. Apologies for the transitions. It's hard to drive for somebody else. But,
yeah, I felt it. I felt a bit like, Wheel of Fortune. Vanna, can you spin the wheel? Right. So thank you.
Thanks for rolling with it. Yeah, so real quickly, we're going to just focus on one of the other papers that have come out since that original RCT. This is one that was published in JAMA Network Open back in late 2023. As Amy said, what we learned from both the original and the second paper is, well, we saw some really encouraging things, access to social programs like SNAP. We didn't have complete visibility into everything that we were connecting the patients to on the social side, but certainly we're encouraged to hear that. The ambulatory care, primary specialty, and DME is also encouraging, but of course, we didn't see the readmissions, we didn't see the ED visit reductions, the prescription drugs. We thought that it would be hard to operationalize kind of what it is, what we're trying to do, because it's not necessarily more prescriptions, but kind of the right prescriptions through our medication reconciliation process. But all that this said is we saw some encouraging things and some things that were a little bit disheartening. And so, I think one of the caveats that when we saw those results, obviously, we were it wasn't, a completely perfect picture, but we said, well, not everyone in the intervention group, got the intervention. There was, so much variation in our ability to get uptake in the program. We had incredible staff who worked really hard to go to the hospital bedside, build the relationship, the trust to have, a person, stranger, enroll in this program, enroll in a study, a research study in a marginalized community where there's distrust for research, knowing someone's going to come to their home. We had great ability to enroll, but we knew that, sustaining that relationship is difficult. Sometimes our teams would go out to that first home visit and never be able to find the patient. So, there was significant amount of variation in the quote unquote dose that our clients received. And that can get lost when we're just looking at the average effect. And so, working with some researchers out at Kaiser Permanente, we used a new methodology that they developed called distillation that recently won acclaim from Health Services Research for 2022 Methodology of the Year. Basically, what it boils down to real quick is just categorizing patients as engaged participants or non-participants using only baseline characteristics and a machine learning-based approach to predict the probabilities of both the treatment group and the control group using only characteristics at baseline, and essentially capitalizing on that RCT framework to find sub-comparison groups within the RCT. And as we did that, there were some really key differences that stood out to us. You know, some characteristics that really had a pronounced impact on our ability to engage with individuals. So you see here the green line indicators were things that were really disappeared when it came to the folks that were the most likely to be considered engaged participants in the model. They had significantly lower rates of homelessness. They had significantly lower criminal justice involvement, lower substance use history. So those were characteristics that if you had those, it meant that we had a harder time engaging with you. And on the flip side, you see there's clinical conditions that meant we had more success at getting a more sustained relationship with our program. And so we saw this as, well, first, this is a roadmap to understanding, well, who's more or less likely to engage in our model, and what can we do with that information, which we'll circle back on in just a moment. When we then looked at these subgroups and re-examined our readmission patterns, we saw that as you get an increasingly concentrated subgroup that's more likely to engage with the model, we did in fact see that those engaged participants were significantly less likely to readmit at 30 days, at 90 days, or 30 days, 90 days, 180 days, in various ways that we operationalize the variables. So encouraging, obviously we didn't see that impact across the whole group, but when we narrowed it down to the group that we're most likely to have that successful engagement with, we did. So what does that mean? What did we take away? Well, you could imagine this could lead to two approaches in thinking. One would be, can we refine our inclusion criteria, limit our patients to just those that are most likely to engage, which, maybe means ruling out people with housing instability or criminal justice involvement, some of the most socially complex patient populations. We could just run the model, where we know it works. On the converse, we could also then spend more time figuring out, well, how do we better engage those subgroups? And at the Camden Coalition, our focus has always been, let's talk about the most complex patients. And so we opted for the latter. And our priority in the past few years has been really trying to deepen our model's ability to work at that more extreme tail. And so these are some of the programs and new kind of evolutions of our model that we've been implementing in the years. Some of these obviously predated, all of these predated the JAMA article. These were gut feelings that we had about, based on our experiences with clients, where we were working or where things weren't working well and how we needed to expand it. So building our own housing first program, so we weren't just referring out to existing housing services, medical legal partnership to better engage individuals that had recent criminal justice involvement. All of this has really been about diving deeper into the ecosystem of care and not just providing care coordination and supports, but really fundamentally reshaping the landscape of service delivery in our community. So with that, I think, Laura, we want to open it up for any couple minutes of questions on the science, and right?
Yeah, I mean, we already have actually a great question, a couple of questions about the kind of methods and science that I think we should just take a few minutes before we launch the panel conversation to have you and Amy kind of weigh in on. Madhuli asks this great question, which I feel like comes up a lot for researchers in this space about, what to do when an RCT is not feasible. And I feel like JPEL has really helped me think like RCTs may be feasible even when you don't think that they might be feasible. But I think that there's also this question of like, well, what about when really it's not possible, or you can't sell an RCT in your population or setting? And so I would love it if you two, both Amy and Aaron, would maybe comment on this and give people some ideas. And I also will encourage people to check out some of the work that has been done on quasi-experimental studies and propensity score matching by people like Seth Berkowitz in our field. And there's just some like really creative work on this, but I think hearing from Amy and Aaron about their thoughts on this will be helpful.
I think, Amy, if you want to take it away, because I mean, you have experience on both sides. But...
Sure. I mean, I'm very sympathetic, right? RCTs are often, I think they need to. First, a key issue is the ethics of randomizing. There needs to be equipoise where we don't know already what the impact is, and there needs to be scarcity. So in this example, despite the considerable success and funding that the Camden Coalition had achieved, they were at the time that we started talking to them in 2013, 2014, reaching only about half of the patients that met their eligibility criteria. So all we tried to do was come in to make that systematically random rather than ad hoc. Likewise, the Oregon Health Insurance experiment came about not because of researcher researcher pressure, but actually because the state of Oregon had limited funds to expand Medicaid, and they decided, based on conversations with stakeholders and the community, that the fairest way to allocate a limited number of spots was to run a lottery, to randomize, rather than privilege first come, first serve. So that being said, often, well, so then the question is, why might an RCT not be feasible? Sometimes, logistically, you can't figure out how do you randomize, how would it work? And one thing we work with a lot of people on at JPL North America is seeing if there's an encouragement design. Like, for example, everyone's eligible for health insurance, but maybe not everyone is signing up. Can we partner with someone to send out text messages or letters to try to encourage people to enroll in benefits for which they're eligible for, which not only benefits them, but then you have some people are randomly sent these encouragements and others aren't, and you get more enrollment in one group than other, and you can study it that way. We also talk a lot about how to make the RCT cheaper using administrative data. We did a great job with that with Camden. But all that being said, I understand that sometimes there's issue. We often will sometimes discourage an RCT if there's not sufficient sample size and power. You don't getting an imprecise zero is not that useful. So we talk about, do you have enough sample size to detect something that would be relevant and interesting to your group? Another issue that can come up is so I'd say sample size is a big one, and power to detect relevant, interesting effects. There's always, of course, just looping back at the at the start, there's always something to be learned from non-RCTs, everything from qualitative research. And I was excited to hear Laura describe this upcoming panel actually talking to some of the recipients of the Camden model. That's how we form hypotheses and refine them. Descriptive analysis is always useful. And so we would never say, don't learn from the best available matters at hand, but we're also always happy to talk. And often an RCT can be much more feasible than people realize. So hopefully that, and as I said, we're more than happy to at JPL North America to talk with people if they have questions. But as I said, we don't come away from every conversation with, oh yes, you should run an RCT. And usually the biggest reason not to is if you're not going to have the statistical power to detect the kinds of effects that would be meaningful to your organization, then not only is it not worth the effort, but it in fact can be counterproductive, because you're going to think you might think you had no effect when in fact you just don't have the power to detect a meaningful effect.
Thank you so much, Amy. There's another question just specific to methods before we turn to the panel, that is just a really detailed question about, did you compare your results against an intent to treat method versus, where you landed, or to compare your results to an intent to treat?
So I think that's more of a question for Aaron, because the original RCT was in some sense an intent to treat. It was, we compared people randomized to the treatment and people randomized to the control group. And then of course we tried to describe what the treatment was that people received. I think what Aaron and his team were doing, so we're more trying to get at a dose response. So I'll let him take that.
Yeah, I mean, at the core, what we're trying to do is create a comparison group to that intent to treat and look at, well, who's that subgroup who we did treat and what does it look like? And can we find a equally balanced group within the control group that looks like, our intervention group, everything. So very much of what we did is a comparison to that.
Great. I think some of these other questions, maybe we'll leave for the panel. So Chris's question, I think we'll leave for the panel. And maybe one clarification question from David before I let the two of you, before I release you, which is just, can you clarify for everybody what the care coordinators do in the Camden model? Because it's my understanding is it's very much not only medical centric. There's a lot of other work that's going on. And so I just want to make sure that our audience is aware of the kind of comprehensiveness of the model. Aaron?
Of course. Yeah. So sorry I didn't go too far into that because we could spend the whole hour just talking about that. But, they meet the patient at bedside. They do care planning that is centered around 16 domains of care. Vast majority of those are non-medical, but working on everything from addiction, housing stability, social supports, getting people access to basic documents like their driver's license or things that are kind of cornerstones to getting additional social benefits. Just trying to get that work started upstream in the hospital. But as soon as they get home, we know that that's a vulnerable moment. So we've got the goals of, this is kind of describing where we are during the course of the RCT, and this has continued to evolve, but getting to someone home within a week of discharge, because so much of our work, while we might kind of understand what the barriers look like in the hospital, they change as they get back to the community. So being able to see people in their in their home settings or wherever they feel comfortable is kind of a key piece of it. So we're doing that. We're getting patients connected to rapid primary care and specialty care, which is obviously at the heart of the health affairs piece, and demonstrating that that was happening with robustness. But a lot of it is just helping kind of take what are the patient's goals, whether it's a healthcare goal, whether it's a employment goal, a just very generalized sense of what is meaningful to the patient, and make that a reality. So we can certainly, I encourage you guys to follow up if you have questions about the model, either our website or directly to our staff, because we do a lot of teaching and spreading of it.
Thank you so much, Erin. I'm going to now turn, actually, Erin, if you could direct your attention to maybe in the chat or Q&A to the question about how you measured high patient engagement, that would be great. But meanwhile, I want to get to our panel, because even in our prep for this conversation, these people would not stop debating with each other. And it was so fun. Apparently they have done this before. They have sat down together in Kansas City over barbecue and just had a lively debate. So we're trying to recreate that feeling. All I am is the person serving food. And then hopefully you guys will chew on it. So I'm going to start with a question that really came directly from our prep session. So when the 2020 study was first published, I feel like there was a lot of surprise and obviously dismay. Amy, you showed that great slide where people were like, well-touted model, lots of disappointment. But then these amazing follow-up studies came out, and I get the sense that people didn't take as much notice of the follow-up studies. And in our prep sessions, Kedar made the very good point that this series of studies is really not that substantively different from many pharmaceutical trials, where there might be no effect in the general population, and then they report that the new medicine works well for some select populations. So I guess my first question for you guys is the bar being set differently for social care integration studies in some way than it is for pharmaceutical trials or for other things that we do in the healthcare system? And if so, why? Chew on that. How's that?
Well, you've served us up well. You haven't plied us with beers, though. That was part of the deal when we did our
show up drunk, Kedar. That was
it might be too early in the morning to do that. Yeah, well, maybe I'll start, and then Damon and Kathleen just jump in here as well. I mean, my sense is that we are we treat social care programs differently than we do common clinical interventions like a chemotherapeutic agent or a novel antibiotic or otherwise a new vaccine. And the truth is that when we deploy those clinical interventions into complex social circumstances, take the vaccine, for example. The vaccine, if you look at it at a population level, the vaccine had a COVID vaccine, excuse me, I'm referring to the vaccine, but the COVID-19 vaccine had very different population level effectiveness depending on where the vaccine was deployed, right? The vaccine proved efficacious in clinical research studies, yes, but its effectiveness was highly variable depending on the social context in which it was deployed, depending on the trust levels of the community, and so on and on. It's not that we thought that the vaccine didn't work, right? We just recognize for biomedical interventions like chemotherapeutic agents and vaccines and antibiotics, we recognize that they work differently in different populations. Why is that different for a social care intervention? Of course, it's going to work differently in different situations, right? I mean, that's just obvious when I say that out loud, but somehow we treat this as a different phenomenon for social care interventions versus biomedical or clinical interventions. So yeah, I think there's a different standard, a double standard. around social care interventions that's particularly problematic.
So I want, Catherine, I feel like you're going to want to jump in there. And before you do, I'm going to plant one other question for you to respond to both, which is knowing that there probably is some kind of double standard. And as you reflect back on this amazing collaboration that you have done for over so many years, would you have done anything differently? Would you have published differently? Would you have chosen different outcomes? Would you have sequenced the release of things differently? Like what, yeah, would you have done anything differently? But also, is there a double standard and how does that affect your work?
Yeah. So, and my mic is on, right?
It is.
Yeah. Great. Okay. Because just like being in like some kind of bar setting, of course, my computer isn't working and I'm on my cell phone and who knows who's going to call me and I'll get something will bleep up on my screen. But anyway, yes, there's a double standard. I was very happy to sort of embrace that double standard. I spent 10 years at the Children's Hospital of Philadelphia, 7 years in the Research Institute. I'm a lawyer and a policy person. And I just thought, we need to do this work. And I took this job not knowing whether we would have a null effect or not null effect. And frankly, it didn't matter to me because I wanted to dig in the way I saw CHOP researchers dig in on cancer care and all sorts of other things. And so I'm just committed to learning more in this work that are some of our most complex problems and people who really, really need our help. So that's the first thing. Would I do the study differently? I mean, you know, yeah, I would probably have planned my day differently today with hindsight, right? So yes, of course. You know, I think that this study was caught up in the energy of the ACA and new CMMI and the money that was available. And so we threw caution to the wind around some things, I think, because we could and the opportunity was available to work with Amy and her team. And we don't regret that because we've learned so much, but we're more seasoned now. And so we would think and are thinking a lot more about things like the drivers of ED use and the drivers of admissions. And are those drivers different for different populations? And we're going to know a lot more about those things and think about those things. And although we would never say that readmission isn't an important metric and could even be a primary metric again, we would be looking at other things like what's important to the patient.
I love that. And I actually know that you've been exploring a suite of patient-reported patient experience measures. I think, Damon, you've done some interesting work back at Health Leads on patient experience measures. Siren's now doing some interesting work on patient experience measures, things like trust in the healthcare team, feeling cared for. So, okay, so based on your collective experience in healthcare, which is actually quite vast, I just want to say, whoa. Do you think we can meaningfully bring measures like that into the payment space in coming years? So, like, in other words, will policymakers start to care about patient-reported outcomes at this moment in time? And if not, how can we change that? And that's fair game for any of you because you all have so much experience here.
I want Damon to talk because he's got some really good, like, you know, let's disrupt this. So anyway, yeah.
Well, yeah, our conversation, I think it was in Memphis, was, you know, a lot about model versus method, right? And I think another place to think about the kind of analogy between chemotherapy and you know, and studying complex care interventions is the basic science of it, right? Like, what's the basic science of complex care interventions? And I do think some things I maybe wish were thought about, and maybe they were and dismissed, but there were RCTs, for example, showing housing first interventions reduce healthcare utilization, right? Like, if we have transitional housing available for you along with care, those RCTs were completed by the time this trial was done. There were RCTs on critical time intervention, which is, you know, an intervention for people who have severe mental illness and homelessness. It's a 9-month intervention, not a 3-month intervention. There's a model behind it that says It's 3 months to transition to the community. It's 3 months to try out what your natural supports look like in the community. And it's then 3 months to transition to those natural supports in the community caring for you. So there were other theoretical models about how the social system works. And I think as Kedar pointed out, like that's the analogy to the biology, right? That in that is like, we really have to do really good basic science on the social system, which means really good understanding of like trauma at a community level, trauma at an individual level, really good understanding of payment models, really good understanding of the social services architecture. All that really has to be kind of deeply done. And I feel like that's one of the lessons that's come out of this, but it's a lesson that maybe could have gone better into the design of the trial too. There was a lot of pre-existing science, and the division between sort of the medical side and what the community mental health world has learned, what SAMHSA was calling evidence-based interventions well ahead of this trial already knew. And just, I think for patient-reported outcomes have a lot of work to do for us in that space of helping us kind of understand how these interventions work, where they don't work. I think they're really difficult to use as accountability measures. I think there's been some great work in the UK trying to advance the work there. There's some places where maybe they do work as accountability measures, post-surgical outcomes, things like that. But I think in this space, the real space for patient-reported outcomes is where you talked about us using them, Laura, which is like trying to figure out how do these things work, how are patients changing as a result of our interventions, and then once we have some confidence in a model, then doing the RCT.
I mean, I guess I would say, just to add on to what Damon's saying here, is that I'm not sure these measures are ready for payment yet. There's still a fair amount of work that has to be done on PROMs, on public confidence measures. Trust measurement is at the earliest stages, I think, of its evolution. Measuring actual measures of trust and public confidence. We have like kind of very poor proxies for that with CAPS measures of whether patients feel like they're listened to and respected. There is a relationship between listened to and respected and a sense of likelihood to recommend an institution. So Press-Ganey has showed a relationship between staff and patients feeling like they've been listened to and respected, and then their willingness to recommend the institution. But these are pretty early stages of these measures, and to start to use them for public reimbursement, I think we're still some time away from actually doing that. That said, policymakers, I think a short 5 years ago, really didn't spend a lot of time or energy on workforce well-being, right? Just as an example of something completely different. But there was really not much in the public domain about workforce well-being or research monies allocated towards it. Now NIH is funding it, the Core is funding these activities. There's major kind of investment in these areas, at least from a research perspective. But I think we're still far away from meaningfully bringing measures of patient-reported outcomes or experience into payment, formal payment mechanisms. I think we're dealing with kind of not so great proxies with things like readmissions.
Can I push you on that for a second, Kedar?
Yeah.
So we now have quality measures that are, did you screen for social needs?
Yeah.
We definitely did not think that was going to happen. And now they're tying it to interventions to quote unquote address social needs. And there's no link to the patient's experience of that care, which I think is a shocker. And we are going to be like, I think in 2026, we're supposed to be paying for those measures. So what is it? Do you think we should just like roll back those measures because we can't then also have any confidence in the patient reported experience of them? Or should we just like dig in on the science really, really fast so that we can add to the, make those measures that exist that are about, quantity, what you're doing, as opposed to the experience of what you're doing, like catch up really fast? Do you have a thought about that?
I mean, so you're referring to the addition of the social needs, the health-related social needs screening measures to the physician fee schedule, right? We are now being
not just the physician fee schedule, but also in the CMS inpatient quality reporting.
Right. And also in the, right.
And
Yeah,
and
exactly.
CPA.
And there's actually some funds now for responding to those detected social needs, which when we were on that committee, which you reminded me about in the introduction, it's shocking that it's been 5 years, but when we were writing that report, I don't think we could have anticipated. We knew about Z codes and some of these things, but we hadn't actually seen them being materially utilized and certainly not being reimbursed in the way that now is being considered and is part of the system. So that's an example of meaningfully changing, payment around measurement, but it takes what, 5-10 years from the birth of those measures to now starting to be added to the physician fee schedule, to the inpatient quality reporting measure schedule, et cetera. So it takes some time, I think, between discovery and study of these measures and then inclusion in payment schedules. So I'm not suggesting for a minute that it's not possible to do this. It's a matter of accelerating the research around trust, public confidence, PROMs, et cetera, patient experience measures, so that they are brought into the fee schedule in the way that we might hope for.
Love it. Love it. Kathleen, did you want to weigh in on this one too? I know this is a hot topic, which is why we're calling it a hot topic conversation.
I think the only thing to say is that on the ground, our care team is I would say we're trying out a lot of different things right now. But it's not like there's one thing where I would take to a bigger study right now and say, yeah, we're absolutely going to use this. We're ready. So we've been.
You're talking about the measures?
The measures, yeah. We've been involved in the NCQA, patient reported outcome study. Our staff, we have, the experience of that. We've used other things. But I just would agree with Kedar that we are very early in. And 10 years from now, we're going to say, oh, we sort of jumped really, we sort of nosedived into screening without having all the right measures set up in advance. And then we'll, sort of adjust and reframe then again too. But I do think, Laura, to your question of should we be doing, rapid studies now to at least get a little bit better prepared? Yes, I think we should.
Yeah. Can I just say, I think Kathleen's prediction is right on. Like the 10 years from now wince, like we're going to have that wince around these measures and how they're used for sure. And I think for some of us in the world of trying to translate to research into policy, like you just have to be okay with that sometimes. Like the bigger picture of the healthcare system is paying attention to the main drivers of the health of their patients, even if they're so gung-ho about it, they're using the wrong measures to think about it, and maybe they adopt problems in the wrong place. The big picture of that is really, really valuable. And like, I have a lot of nervousness, I think, as Kathleen does, around like how that's actually going to roll out in the way that we're implementing it.
Yeah, whether or not it'll be meaningful. That's super helpful. And I appreciate your positive frame, Damon. Sorry, Kathleen.
Well, we were an accountable health community site, and we did thousands and thousands of screenings, right? We never in a million years of CMS said, what we're going to do about this is based on what the Camden Coalition recommends to us. We would never have recommended to start in inpatient with this ever.
So
right? But
interesting.
So, but it's not necessary, but we're happy that it's starting someplace. But that's not where any of the screening was really happening in the whole AHC world. It was all happening out in the field, in primary care, in emergency rooms, in places where we know people are showing up with urgent, social need.
Oh my gosh, I actually want to delve into that more, but I'm not going to. I'm pulling myself back because the focus of today's webinar should be more on Camden, but it's making me realize that we need to have another conversation about the measures some down the line. We did one with the amazing group at Princeton. Oh my gosh, I'm having a senior moment of the name of the group at Princeton that does all the Medicaid work. Sally, put it in the chat. Yeah, so that I get there. But we do have a recording on the measures, and we should continue that conversation. But in the meantime, there's some great questions, and I want to get to it. So Oscar asked this amazing question about, okay, so say you have unlimited resources. You learned all this amazing stuff. You now have unlimited resources to put it into a staffing model and what would be that new model? And Damon, Kathleen, Kadar, all of you have experience in like telling people what to do, how to do the best complex care management that you could possibly do. What would you tell them to do? And I feel like I want to contextualize that in so many states are trying to do this right now under their waivers. And certainly the federal government is trying to do this in lots of different policy forums. They're trying to give people the flexibility to do it. What should they do?
I would start with primary care. I would start with health insurance. So, everyone should have health insurance. You should maximize the number of insured people in your community and the continuity of their insurance, because that completely changes the environment around having to do care management. Then you should make sure that people have access to primary care, and having insurance and having access to primary care are totally different. And you need to tailor primary care for different groups. There's been great work, Stefan Cortez and folks in homelessness around what tailored primary care looks like. And then I would have the care management functioning as pre-admission work and then reaching into the hospital to get their patient when they go in the hospital. That's the kind of overarching structure that I would advocate for.
Other folks?
I don't disagree with that. I love that model, Damon. I'm going to come work with you on it. So, I think the continuity around health insurance is critical. And I think that the redetermination that's happening now has sort of, I think, brought to the surface just some of the infrastructure issues that make even redetermination on an annual basis painful. And so I hope that leads to some modernization of how it's done, and maybe some final realization that this annual re-up is really just a waste of resources. So that's one thing. I think that, I think what all of these studies have shown is that care management for some people it works on a short-term basis, but some people need care management longer than 9 months. I mean, what the Housing First program that we run, that we created in the middle of our RCT, shows us is that we have people now that we've worked with for 7 years. And actually, I can say for 7 years, they've had the same community health worker because, we pay our community health workers really well and treat them well, and they stay around. And so, we have to think about continuity, not just of coverage, but continuity of care team. And that also means thinking differently about how we take care of the people caring for these folks. So I'll stop there and give it to Kadar.
I mean, I'll add only a couple of things to what you both have already described. And the things I would add are that I think that distinct populations require distinct interventions, right? I mean, I think one of the findings of the subgroup analysis is that you do have the intervention effectiveness is varied depending on the nature of the population served. So to me, developing, and that's what Camden admirably is leaning into, instead of doing what pharma would do with this type of a finding, which is just give the medication or the dose to those that do respond, you are trying to adjust your intervention admirably to meet the needs of the population that you actually are dealing with, which I think is appropriate and the right response. And I think that just tells us something about the fact that you need some customization, some tailoring to different heterogeneous population segments that are really important. The other thing I would say is that you alluded to this, Kathleen, in your community health worker comment, and that's this notion of some kind of peer support system. Almost every, really good complex care system has some form of people going through the same experience of life, helping other people who are going through a similar experience in their lives. And whether that's done on a one-to-one basis or in a group mechanism, to me, that is what we get when we're trying to really co-produce outcomes that matter to people. there is a technical dimension of all of these interventions, and there is a relationship or social dimension to all of these interventions. And that notion of peer accompaniment or support is really reaching far beyond the technical into the relational dynamics that I think are vital to co-producing a better outcome for these populations. So those would be the only elements that I would add to what you've already beautifully elaborated.
I love that, Kedar, and I feel like that's really consistent with the conceptual model work that we've been working on and recently did a webinar on. So for people who are interested in that idea that there's like lots of different mechanisms here through which we're improving people's experiences of health and opportunities for health, it's yeah, please check that out. I'm torn right now because we have so little time and there's so many good questions to ask you. So I'm going to ask one more question. And David, you'll have to forgive me. I love your question, but we're not going to get to it today because this was a very complex care-oriented intervention. But when Camden talks about the lessons learned, as Kedar was mentioning, you guys have you really underscored that this is not a patient-level intervention solely. This has to be ecosystems of care. And I loved watching the Better Care Playbook webinar about the work that you've been doing because you've like doubled down on, we have to do something differently for those populations we weren't reaching in that, or the intervention wasn't as effective for. Damon also has done like crazy good work on thinking about ecosystems of care. And I want Kathleen for you to share maybe a couple of the things that you're doing at the community level that are augmenting the work that you're doing at the individual level. And then if we have time, I'd love for you to talk about, could we study those? Like, are those studyable or is that like out of the range? And Damon, feel free to weigh in on this too. I'd just love for you guys to reflect on that.
Sure. So we are doing right now a behavioral health intervention, and really a lot of our work right now, in addition to our work with people in care management, is with our partners in the coalition who are competing health systems, really competing, community certified behavioral health centers, right? Sometimes competing housing providers, and we're working together to try to actually think about how we redesign how we work together. So one example, we know that if we catch somebody in the emergency room right now, based on work that we're doing, where we have helped our partners, CCBHC, embed into an emergency department and help someone in the emergency department at that time get connected to the CCBHC for outpatient care, 90% of the time they show up. If we connect with them any other way, through phone or whatever, it's really like 30-40% of the time, right? So we're trying to think of other ways that we capture those people who show up. So one of the things that we did with all of our partners, this is 4 health systems, 2 community behavioral health, certified community behavioral health centers, is we said, let's all look at the past 6 months and which patients are showing up to all of your emergency departments for behavioral health. And what we found is in an area of 1.5 million people, so that's the geography, 2 people showed up to all 4 emergency departments for mental health issues. 53 people showed up to 3 of the 4, and 500 plus showed up to 2. So the question is, how can we get together on those people? And we actually are starting to hold cross-system case conferencing on those people who are at that extreme tail. So that's just one example of changing the ecosystem, changing how we work together.
I love it. I am so embarrassed at what a terrible job I did moderating today because it can't be 10 o'clock. I mean, no one should ever let me moderate a conversation again. I want to thank all of you for joining us. I want to give Kedar the last word because he wrote me a message saying, I need to make a last comment here. And I would really like to hear from you. But before you
I just want to say that I think, first of all, I just think that the work that, Camden and JPAL did is remarkable and somewhat unheralded in the field, right? We don't do enough of this, really honestly looking into what we do, how we do it, doing subgroup analyses, breaking down an initial study and doing this kind of work. And unfortunately, a lot of that additional work gets lost in a very simplistic headline that, you know, care coordination doesn't work, or Camden's hotspotter model doesn't work, or some nonsensical oversimplification of the truth. And if anything, I referenced the pandemic earlier. If anything we've learned is that science communication has to get a lot better. And we are just not doing, it's not enough just to do the study and then write about it in whatever journal you wish to publish it in, and then hope everybody will read it and care. We have to actually go another step, well beyond that, to help people really understand what it is that we're learning, and help people go beyond that initial study to what else do we need to comprehend about these issues in order for us to get this out there, so that not just us internally as a research community understand it, but the wider public doesn't adopt a false frame or a false narrative that care coordination doesn't work, or whatever narrative might emerge from such a study. So we really have to do this job of communicating science more effectively.
You're getting so many hearts and so many thumbs up, and that is the perfect ending to a fantastic conversation. So grateful to Aaron and Amy and Kadar and Damon and Kathleen, and to the entire Camden Coalition team who helped us put this together. We will send this out to all registrants, and hopefully you'll send it out to all your friends. Thank you all. Have a wonderful Friday.